So I think in pediatric sickle cell disease, if we were to take a global view on that, and I've briefly mentioned that before, I think we really need access globally to screening programs and proper treatment programs for regardless of where these children are resident. So for instance, access to penicillin, access to hydroxyurea, access to vaccines, access to antimalarials if necessary, that is really vital. I also think that we really need to push for much wider uptake of hydroxyurea and start it very early so that we can stem the sort of inexorable journey of the body organ failure that the patient is going through. So I think that is really important. We should be doing with pediatric sickle cell. We also really need to think about, if you've got access to curative treatment, what sort of time is right to provide those curative treatments. And I think that conversation needs to continue to happen. We need to continue to engage with patients to see what is the risk and benefits currently of these curative treatments and how much patients are willing or families are willing to the trade-off in terms of how much are we willing to sacrifice quality of life as an adult versus willing to sacrifice sort of long-term side effects of these interventions. And I think polypharmacy is here to stay in some ways. Sickle cell is a multi-system and complex pathophysiology, and there are very many ways in which you can approach it. And so therefore I think with childhood as well, there are new drugs and therapeutics that are coming in, and I think combination treatment may be the way to go for patients who will not have access to curative treatment straight away.